discussion on brain tumors. As every year we observe World Brain Tumor Day on the 8th of June. On that behalf, we will be having a discussion on brain tumors. I am having with me expert panel which consists of neurosurgeons and neurologists. So I am having with me senior most neurosurgeon, Dr. Mahendra Chitre sir. He is having experience in neurosurgery of more than 30 years. In the field of neurosurgery. I welcome you, sir. I am having with me more than 10 years in the field of neurosurgery. I welcome you, Dr. Mandar. So we'll be having, I hope that we'll be having a very informative discussion on the subject of brain tumors. So my first question will be directed towards Dr. Sandeep Borse. That there are more than 30,000 patients as per the epidemiology who suffers from the brain tumor every year in India. So what are the common symptoms which the brain tumor patient might present in the OPD of a neurologist? So here it is.
Okay, this is the most important question. So for in general, any patients or any person who is suffering from the common neurological symptoms like headache, or imbalance or blurring of vision with headache, or seizures or convulsions, you can say fits, who get fits, or any person who has headache and confused state, or many times imbalance of gait, urinary incontinence, stool incontinence, which was not there before, and slowly persons may have slowly cognitive and deterioration, memory loss, and one side of hand or leg might get numb or weak slowly over a period of few days along with headache. These are one of the few common symptoms, neurological symptoms which can present like a brain tumor, and then you should visit a neurologist or neurosurgeon for the further workup.
Thank you, sir. So I have a question that headache is being so it's so very common symptom which is observed in the day-to-day OPD. So is the headache found in the intracranial masses of the tumors different from the headache of the migraine, or let's say tension type headache, or for that matter the TACs? So can you elaborate on that subject, sir?
So headache is a very common symptom. Every household has a headache patient. Okay, so that doesn't mean every person has brain tumor. So most common cause of headaches are migraine or tension headaches. So how to differentiate between simple or migraine headache, safe headaches, or danger headaches? So migraine headaches, patient will have shifting pain all over the head. They will have sometimes nausea, sometimes vomiting. Travel will trigger the headache, or irregular sleep habits will trigger the headaches. Long screen exposure will trigger the headaches. They will have sensitivity for lights, sound, and sometimes in females during periods hormonal changes may lead to increase the headaches. So these are the all precipitating factors which will increase the headaches. So these type of headaches are long duration headaches, last for 4 hours to 2 to 3 days. Irregular eating habits also trigger the headaches. So these are kind of migraine headache or stress tension headaches. And now coming to our danger headaches, which may lead to a diagnosis of the brain tumor. Those headaches are localized headaches, which are localized to a particular part of your head. Headache with blurring of vision, headache with vomiting, any new onset headaches. Headaches with other neurological signs like slurring of speech, facial deviation, or unilateral hand weakness or leg weakness, imbalance during walking, or headache with confusional state, headache with forgetfulness. These are the danger headaches. Postural headaches are also important. Person who have headache during standing and relieved on lying down, or person who has headache during lying down position and relieved on standing position. These are postural headaches. May also suggest change in brain pressures. So especially night headaches which worsens in the night, and early morning headaches are danger headaches, because these are the headaches which suggest there is an increase in brain pressure. So we have to evaluate further for any intracranial pathology or intracranial pressure changes or brain tumor person.
Thank you, sir. That was a very elaborate explanation for the headaches, which differentiates between the common headaches, which we call primary headaches, and the headaches which are caused by the intracranial masses. So I have a next question which is directed towards Dr. Mahendra Chitre, sir. That what are the common intracranial tumors or the brain tumors which are encountered in the day-to-day OPD in the neurosurgery department?
Yeah, I mean, we may have to make two different groups. One is adults and one is small children or pediatric group. So in pediatrics, we have certain tumors which are common, pediatric brain tumors. They are medulloblastomas, astrocytoma, and some of these tumors which are there right at the time of birth. They are there, like some of those round cell or malignant tumors, some of the germ cell tumors, which are common in children. And then craniopharyngioma is a supracranial variety of tumor which is common in children. So in children, these are the common things which we see. The arachnoid cyst also, which is congenital many times, presents like a tumor, which is called a cyst, but it is actually not a tumor which grows. In adults, we have tumors which occur in intracranial cavity. So now we have different things or different cells in the intracranial cavity. They are brain cells, they are supporting cells of the neurons, then there are blood vessels, there are coverings over the brain, which are called meninges, and there are blood vessels. So all those different structures, they can give rise to different tumors. So tumor arising from blood vessels, tumor arising from meninges, like meningioma, tumor arising from astroglial tissue, which are supporting cells in the brain, parenchyma, which are called as gliomas, astrocytoma, which has got different grades, 1, 2, 3, 4. And some of the tumors which are common in women, like meningiomas. Then we have certain tumors which are occurring because they travel from other parts of the body coming into the brain, and which we call them as secondaries in the metastatic tumors. So metastatic tumors, some of them come from prostate, breast, or bone, or different other areas like lungs can come up. Thyroid is another one, which come up as secondary brain tumors in the intracranial cavity or in the substance of the brain as such.
Make it simplified, tumors basically can be classified into two groups, what sir was trying to tell you. Basically, they are primary brain tumors which are coming from the brain and brain tissue and surrounding tissue of the mentioned, and there are tumors which are secondary brain tumors which are coming from other part of the body. They are not arising from the brain, but they are coming from the other parts of the body to the brain. They are called metastatic tumors. Now, primary brain tumors can be simple tumors or malignant tumors, but a metastatic tumor will always be a malignant.
Your experience, Dr. Mandar, on that?
So basically, as we discussed, there are tumors primary to the brain and secondary from the other parts of the body, metastasis. So why this is important? So we stage the tumors according to the growth rates or chances of recurrence, and these stages are very important for the recurrence, if the tumor will recur, and what is the prognosis for the patient. Okay, so the benign tumors generally they don't recur. When we excise them, the patient is cured of the tumor, and if there is any recurrence, but it will only be the local recurrence, so it will be not life-threatening per se. But in case of malignant tumors, as the name suggests, it is life-threatening to the patient, and so we, for simplification, we stage the tumors or grade the tumors as grade 1, 2, 3, and 4. So according to these grades, there will be prognosis of the patient. Like in grade 1, there is 80% 10-year survival rate. In grade 2, there is 40 to 50% 5-year survival rate. In grade 3, there is 25 to 30% of the 5-year survival rate. And in grade 4, only 5% 5-year survival rate is there. So the type of tumor is very important and staging is very important.
Thank you, Dr. Mandar. So, most of the time when the patient comes with the symptoms as we had discussed, the neuroimaging comes very handy in these kind of patients where we find some kind of lesion. So, there are many lesions which might present as a mass, no? So, they might be neoplastic, maybe benign, maybe malignant. There are some masses which are infective. There are some masses like Sir had mentioned, direct node cyst, which might be from the birth. So, is there any insight? How do we go about these cases, and how we investigate these cases, and how the imaging comes handy in tackling these kind of cases where we differentiate between a neoplastic and the infectious kind of causes and the other causes? My question goes to Dr. Prashant.
So, the basic investigation nowadays is CT scan, which is done in a few minutes, and we can get an idea of whether there is a tumor or not, first of all. To find out whether it's a benign lesion, that means a simple tumor, or a cancerous tumor, there is an investigation called MRI, which I think everyone knows nowadays. And we have now very good protocols done for a tumor study basically. It's called MRI brain tumor protocol, wherein we do MRI brain with a contrast study, with a spectroscopy. The contrast will give us whether the tumor is enhancing, in the sense it is very vascular or not. Secondly, we do MR spectroscopy, which will tell us whether it is infective or it is a malignant tumor. And then there is something called a perfusion study, which will give us whether it is necrotic or it is very vascular. So this is the basic investigation nowadays. MRI was initially supposed to be a very, I would say, very rare investigation initially, but now it's a very basic investigation. About this, like Sir mentioned about metastatic tumors, so we do PET scans to find out whether there is any tumor in the body which is spread to the brain. So this is another addition to the investigation protocol, wherein we want to rule out whether it's a infective tumor. PET scan also can differentiate between an infective tumor and a malignant tumor. So it also helps us that way also. So, and congenital tumors, obviously, they are that MRI findings will tell us whether it's a simple or a malignant. Anything you want to add?
No, I mean, just to add to the same what you have said, that MR is now something like gold standard for us to know that there is a tumor. Only now the spectroscopy has added few things, PET scan has added few things to it, that now we know the chemical structure and chemical activity of the tumor. Earlier, CT scan probably would not tell us more than vascularity, but now with PET and with spectroscopy, we now can differentiate between infection versus highly metabolically active tumor.
Another thing, another thing is nowadays MRI we do something called, now to this to understand how the tumor behaves, there is something called a stratigraphy, wherein we can do a scan where we understand whether the tumor is eating up the fibers, means it's damaging the fibers or it's pushing the fibers. Most of the times when it's pushing the fibers, most of the time it's a benign tumor which generally pushes the fiber, and if a malignant tumor is there, it will damage those fibers and go across the fibers. So that is another addition to MR.
So as Sir mentioned, this tachography or DTI imaging has been added to the arsenal of imaging. So it also helps in planning for the surgery. So which is the safe approach? Where are the internal fibers located? So which is the safe corridor for the tumor? So it's very helpful in that plan.
Very truly said, sir. So as we have known that the brain tumors can arise in the different parts of the brain. There are like different cortexes which are having different functions. Like frontal cortex, which is for your executive functions, for your the personality you possess. There are the temporal cortex, which have a very avid role in the memory, learning purposes. The parietal cortex, which have got the visual-perceptual thing. the occipital cortex, which have role in a visual processes. So, are there any differences when the tumor at a different location present with a different kind of signs and symptoms? I would like Dr. Borse sir to elaborate on that subject. That the location of the brain tumor and its different signs and symptoms.
Basically, brain has frontal lobe, temporal lobe, parietal lobe, and occipital lobe. Okay. So, tumor arising from that specific lobe of the brain or part of the brain will lead to that specific cell, because different lobe has, as Dr. Manish said, different functions. So, every brain tumor arising from that specific location will have that specific signs and symptoms. The headache will be the most common symptoms, blurring of vision will be the most common symptoms. But tumors arising from frontal lobe will have personality changes early. Then they will have psychomotor changes, slowing in the behavior. They may have aggressive behavior, or they may be very apathetic, means they will only sit and stop communicating with everyone. They will stop their day-to-day activity. They will stop doing all these leisure activities. So there will be personality changes, which may suggest some pathology might be in the frontal lobe, or they will have seizures, which are primarily motor seizures, hypermotor seizures, coming from the frontal lobe, mainly at the night, and they will have high motor activity or hand shaking, leg shaking in the night time. Likewise, patients having occipital lobe tumor, they will have mainly visual symptoms. They will have either heavy blindness, partial blindness, or they will have flicker of the lights spontaneously along with headache, or they will have seizures which starts with the flickering of the lights, and then patient become unconscious. And field effects. They will have certain change in hemifield or partial field changes while in vision. Then temporal lobe seizures or temporal lobe tumors will have memory loss, sometimes hearing loss. The seizures, they will have seizures particularly last for a few seconds to few minutes. Those seizures will be having some lip smacking behavior, like the patient will have this, then hand automatism. They will have only some picking movements, and the seizure will last for only few seconds. So even sometimes people don't know he is having, we call it as a simple partial or complex partial seizures. The relatives might not notice, and patient is forgetting about those seizure episodes. They will be amnestic about that seizure episode. They will never tell you I have seizures. Okay, so it is very important to know these kind of seizures can happen to patients. Parietal lobe seizures, tumors as in parietal lobe will have more of sensory problems. Because parietal lobe carries more of sensory problems, so patient will have tingling numbness on one side of the hands or one side of the leg, or they will have sensory masked seizures, like the tingling or numbness will start from the face and then go to the hand and to the torso and then to the legs. So these are sensory masked seizures arising from the parietal lobe. So these different clinical symptoms will tell us from which area of the brain the tumor is arising and how much is the damage to the brain for the patient.
So we can add, there is certain areas like the pituitary gland. If pituitary gland develops a tumor, you can have hormonal imbalance, you can have hormonal problems because of that. Hypothalamus, where you can have this eating disorders, or you can have the sleeping disorders because of those, and you can have hypothalamic seizures also. So those are there. And related to cerebellum, where it results in imbalance in walking, speech abnormality, you have this slurring of speech, or you have this jerky speech, got staccato speech, so you can have these problems related to cerebellum. So as he said rightly, every lobe, you can clinically diagnose a tumor because the lobe will present with those symptoms. Those tumors will present with those lobe symptoms.
To add only one to the symptoms related to the location, few interesting things. If it's right parietal, it has got a more of a visual spatial disorientation. Person may lose to go back to his own home. Right parietal tumors will present that way. They will lose out on the track, on the road, and so they will that orientation to the space and maybe sometimes time and person also can be lost. But maybe children, wherever there's just a vomiting, it may suggest fourth-ventricular tumors because irritation of area proxima of that particular flora fourth ventricle. So these are certain interesting things. Some of the tumors which are there in the temporal lobes, they present with only something like a vertiginous epilepsy, only vertigo, nothing else. You do the scan and there is a temporal lobe tumor. So these are few interesting things.
To add to this, when the tumors, even if they are out of the brain matter, like extra-axial tumors, and if they are nearby the cranial nerves, they can cause specific symptoms like ptosis or inability, drooping of eyelid, inability to move the eyeball, or there is hearing loss in particular ear, and there is facial weakness. So these symptoms are specific to the nerve, cranial nerve, which is controlling that area, and tumor nearby can cause these symptoms.
Right.
Thank you, Dr. Mandar. So I would like to ask Dr. Prashant Khandelwal, sir, that when the patient with particular signs and symptoms and the neuroimaging comes to the OPD, that must be a very big setback to the family and the trauma to the relatives and the patient themselves. So how does the decision making goes around when such patient comes in the OPD? Like how to go about the planning of the surgery, whether to operate, whether not to operate, that kind of thing. So I'd like to shed light on that.
It's a bad thing to have a tumor, first of all. The brain tumor surgery. So, yeah, it is very difficult. Families in the devastated stage, when they come to you, they are in the denial stage also. When you talk to them about anything about brain tumor, they are in a total denial stage that I didn't have any problem, but how did this come to me? First of all, many of them say, did I do this, did I do that because of that? So brain tumors are not related to anything as such. Only few tumors which are, they say that because of radiation can happen, but otherwise generally brain tumors, there are very few which are hereditary. Other than that, there are no tumors. It is just pure bad luck habits, nothing else. Okay, so now how to decide and whom to operate and whom not to operate. So if a tumor is benign, 100% certain, there's no question about it. You have to operate, you have to remove it because it can cure the patient. So first is that. If question comes in a malignant tumor, whether to operate or not to operate. So a malignant tumor means a cancerous tumor in a very dominant location deep inside the brain. With an elderly person, we say, okay, you can take a decision whether you want to do the surgery or not. But in a young patient, we will always do a biopsy at least. In a deep-seated location where it is a very small tumor, not accessible, we do just a biopsy through stereotaxy. That is a very minimal invasive procedure. That is planned accordingly. I will go into the details later. A surface tumor, we go for surgery. We plan for a craniotomy in the sense we open the skull and remove the tumor completely as much as possible, trying to avoid damage to the structure. So these are planned in OPD. On the scan findings, we discuss with relatives about the pros and cons of the surgery, about what is going to happen to them if we do this, if we don't do this, what is going to happen, what are the treatments later with the surgery to be done after. That is all discussed in OPD, and then after that we just sit on with the radiologist or a colleague neurosurgeon and plan the surgery accordingly. Anything else you want to add? Sir, you can.
Yeah, just one step ahead of if it's benign tumor, we have to have surgery, remove the tumor, cure the patient. Yes. But now with lots of new advances, we have certain options apart from doing surgery. We could just do radiosurgery. And if these tumors are smaller, 1 centimeter, 1.5 centimeter size, they could be radiated and burnt, and probably we can almost cure that. So now there are good centers in the world where they have done radiosurgery on small tumors, though they are benign, and there's a follow-up of almost 15-20 years now that they are doing well.
Okay,
So that's
add to that.
yeah.
Only surface tumors, I prefer we should
Go for surgery.
yeah. But then
If they are being
lesions which are very close to cranial nerves,
Yeah,
which
so-
can cause cranial nerve deficit.
Deficits.
Yes, you
So
can
smaller
take
tumors which are difficult to access,
Yes.
they are attached to the different eloquent structures of the brain, nerves, then probably we
Correct.
have an option.
The tissue like biopsy. So like I would like to have like insight into the like that part of biopsy and the advancement in the field of biopsy from Dr. Mandar. Like, are there any procedures which are like less invasive, or are there different kind of biopsies?
So when the tumor is deep-seated and in the dominant hemisphere and surrounding the critical structures, then we may not be able to take it out because we'll have to go to the brain tissue and we may cause more damage than the treatment. So in those circumstances, there is something called as stereotactic brain tumor biopsy. So in that and there is newer advancement like neuro navigation as well. So in that case, the scan is fed into the neuro navigation system, and we can plan the track from the non-eloquent area, and it will exactly give us live feedback. So in which depth we are going, and which approach and which track we want to go.
So it will give a three-dimensional location.
Three-dimensional location and view, and accordingly we can take the biopsy.
So like while getting the biopsy or while planning the surgeries, to avoid the eloquent cortexes is prime most important. So I'd like to have insight from Dr. Prashant Khandelwal, sir, that how do the this imaging like DTI, the functional MRIs help in planning these surgeries to avoid the eloquent cortexes, which are very important for the functional part of the person's spine.
So he said about tractography. Tractography means exactly what I will tell you in brief. Means your fibers which are controlling your arm movements, your full all body movements. You try to trace them in an MRI in 3 dimensions. You get a fiber tracking. That's called tractography. So that once you track those fibers from the surface of the brain up to the brain cell, you know where the tumor is lying according to those tracks. Whether they are pushing them, they are engulfing them. Then accordingly, and again, once you do this tractography, you know the entry point where you can go in for the surgery. So the approaches can be decided accordingly. Speech area, like he said, we can do functional MRI. Functional MRI means what exactly is? Suppose I am speaking in MRI, what they do is they try to define the speech area on MRI. Where is it arising from? The speech fiber. So then when a tumor is diagnosed and we try to find out whether it's involved in the speech area or not. So then in that case, then we decide whether we should do, so that helps in deciding. Let's say it is involving the speech area, it's very close to speech area, then there is a different approach for it. It's called awake cranial, wherein patient is, first initially we do the surgery under sedation and open the skull, go up to open the covering and then make the patient awake completely. And then we start resecting the brain. Is completely painless. So brain is not going to cause any pain. So on brain there will go. But once you touch the eloquent cortex, it will immediately reflect on the patient. Like we ask them to talk during the surgery. Sometimes people ask them to play guitar and all. And we find those changes when we are very close to those things. Then we have to stop the surgery. Other thing which we use for avoiding damage to eloquent cortex and all this sonography intra, which is a live feedback actually. On table, we can find out where the tumor is just doing sonography on table. We can get the feedback from the sonography machine and then accordingly plan our surgery. That is very helpful for us. The neuro navigation is already mentioned where we can get a 3-dimensional image. It's a feed on the TV screen in front of you. Wherever you put your probe or your finger, you can see where you are going basically. So it guides you to tumor from non-eloquent. Non-eloquent means functional part of the brain, which is less, is not going to cause any problems to you when you approach from those places. That will guide you exactly the tumor and you can dissect the tumor. There is something which is new now, which is a software which you can put in your computer laptop. You don't need any big gizmos for that. Just put the MRI feed, MRI contrast studies in the laptop and just read it. It will give you the surface, the lesion in 3 dimensions, and it will allow you to plan your approaches also.
Just to add to the stereotactic tumor biopsy, there is newer advancement in that. So, in addition to the neuro navigation, there has come robotics, like ROSA system. So, it's robotic stereotactic assistance. So, what it does is it has a robotic arm. So, it will take data from the neuro navigation system, and that arm will exactly align with the tract, and it will guide you to exact track. So you just have to insert the biopsy probe and you have to take the biopsy. And there is also Medtronic's stealth automatic. So these arms will automatically give us the align with the track where we want to go. So it's very safe and it doesn't have any side effects.
But mind you, robotic is not yet in use. This is only one biopsy which we can take, but the tumor is not performed by a robot. So you come with us to us that is go robotic surgery for a brain tumor. So I think so it's not possible right now.
Yeah.
See, I mean, it's all multiple things what both of them have said. It's finally, it is something where robotics is coming into the picture. Robotic has been there since 1980s, where small little accurate kind of pinpointing structure in the brain matter was done by computer, was the beginning of robotic. So that was assisting us in stereotactic surgery. It's a part of a robotic system since then. Now it has gone way ahead, and maybe to surgeon it will always help to be more accurate, perfect in its trajectory, reaching the point, and even doing that particular job. Because apart from neurosurgeon himself, there is nobody else who could assist him that accurately. So robot is going to be helped,
So finally,
being an assistant.
Finally, it is a neurosurgeon who is operating the robot, not the robot is operating the surgeon.
Exactly. So, and finally, it's a brain map, which is important, because for everybody, the speech area differs little bit, few millimeters here and there. So your speech area will be somewhere little different, mine will be, these will be different. And at the time of doing or finding the trajectory, we can't be relying on fixed skull points. So we have to go and do the mapping. And that's why exactly locating the Broca's areas, speech area, motor area, visual area is of great importance.
Thank you, sir. So there is one question to the every patient's mind comes, like what are like pros and cons of the open surgeries versus minimally invasive surgeries? So can we have like insight on that?
See, conventionally there are large incisions, big craniotomies and big incisions, because the tumor also were big once upon a time. But with getting these MRI and a lot of accidental findings of small little tumors there in the substance of the brain, way inside and the depth, or maybe on the surface, are found accidentally nowadays. Question comes, do we operate or don't? Do we leave them alone or we just do something about it? But basic is, larger tumor of vascular type will require a bigger craniotomy. Now, there are dictums and the experience of various surgeons, how they were trained. And that's the reason those people continue to operate according to what they were trained with. But the recent now, minimally invasive surgery is really big time. Minimal surgery, minimal invasion is the choice of patient also, obviously. He doesn't want a big scar, big craniotomy defect, or any kind of a morbidity on his face or skull or head. So minimally invasive surgery is a fairly thing, provided it allows neurosurgeon to go in and do his job perfectly. So all those small little pathologies which allow neurosurgeon to do his job perfectly with the smallest of the opening is the indication for minimal of invasive surgery. So categorically you can't categorize. It is exactly the patient, what is his job, where the tumor is lying, what kind of pathology it is, what are the armamentarium and gadgets available at that particular center. That also matters in India. Not all patients can be sort of enjoy the facility of fantastic centers. So neurosurgery now is being done at almost every taluka level in India. District level, yes. So I think there are so many factors to decide minimum invasive surgery. Penetration and removal, aspiration. Clots, if they are in still liquid stage, can be aspirated by doing a small bulb or maybe by even stereotactic planning. And then there are small little tumors which are less than 1 centimeter can be tackled with minimally invasive surgery. Now, people are coming with small incisions over the frontal areas of the face where they have to access subfrontal tumors with just a small little eyebrow incision. Go with the scope because endoscope has come. So, minimally invasive surgery is going along with endoscope and along with better visualization, better what is called we magnify the image. That has really helped. So I think it varies from multiple tumors from small size to big size. Conventional surgery has its own place even today. So bigger craniotomies, bigger opening of the dura, and only one important thing which has come up. The way we used to retract the brain earlier, now we don't retract the brain. We try to minimize because availability of good microscope, endoscope, the retraction even in a small little openings can help us to remove a substantially moderate size tumors.
So to add to it, actually we follow midterm as what is minimal invasive? Minimal handling of the normal brain tissue is minimal invasive surgery for us. Whether it is a big opening in the skull or a small opening in the skull, you have to handle the brain very. That is what he was telling about. He initially used to put this big flat steel plates to retract the brain. Nowadays we don't do that. So that is handling of the brain. So minimal invasive should be, and I have seen patients coming to us, sir, I have tumor on here. So let's say the skull, you can take it out from the nose. It's not that way. You have to let the surgeon decide, because nowadays people do surgeries from the nose also, but there are certain tumors which can be removed. Not every tumor can be removed from the nose. Dr. Mandar, you want to add something?
Pituitary tumors which are very unable to access from nose, and there are certain vesicular acoustic traumas which can be taken by endoscopic route via small incision behind the ear. And intraventricular tumors, there are also they can be approached by endoscope, and certain pineal region tumors, the biopsy can be taken through endoscopic route. So these newer advances has come for endoscopy.
So my next question would be that everything which presents like tumor, looks like tumor on imaging is not necessarily, sometimes it comes out to be something like totally different. Like there are like cases of tumefactive demyelination that looks like tumor, behaves like tumor, but it comes out to be demyelination. There are certain like infectious, like tuberculomas, definitely can present like tumors. There are neurocystic sarcosis. There are different kind of infectious granulomas which might appear as tumor. So I'd like to have insight from Dr. Khandelwal sir regarding how do the collaboration between neurologist and a neurologist.
So first I think Sandeep
Yeah,
is able to answer it better.
Definitely.
And then I will add to it.
Yes, sir. Dr. Sandeep sir, would you like to elaborate on that? That the tumefactive demyelination and the infectious like masses presenting as a tumor or look like tumor.
So again we will go back on history of the patient.
Basically,
First, that is going to
that is the
diagnose
best.
the brain mass. What is So history of the patient is, the patient should give good history. Like a Dadima story, he should tell from day one what started, how it worsened, which factors relieve the symptoms, which factors aggravate the symptoms. So all the story should be told by patient to the doctor, and then specific question we can ask. So brain may have different, like Dr. Khandelwal, Dr. Manish, brain will have different pathologies inside. It may not be tumor. So all brain masses are not tumors. They might be infection, they might be inflammation, because of demyelination, some small lesions, or there might be abscesses also. So we have to ask the patient history. So patient with brain abscess will have headaches and they will have fever. There will be loss of appetite, loss of weight over period of, and the patient will have symptoms which are subacute onset, means from a few days, 2 weeks, 2-3 weeks or 4 weeks symptom onset. Tumors will have long duration of symptoms, but these masses will be having only subacute symptoms like 2-3 weeks, 4 weeks symptoms. So we have to take into consideration of systemic symptoms, fever, any weight loss, appetite, and other neurologists. We have to correlate all the symptoms and then diagnose the patient. Like earlier we discussed, MRI is not going to tell all the answers. We have to take patient history in the count, investigation in the count, blood test in the count, and even the neurological examination in the count. Then only we can manage the brain problems or brain lesions per se. Many times we have to do lumbar puncture, which will differentiate between the normal tissue or there is infection or inflammation. Inflammation means demyelination, because multiple sclerosis, NMO, MOG disorders may show brain lesions which are looking like a tumor masses. And so this CSF or lumbar puncture, which we do small needle puncture to the spine, and we remove the brain fluid, at least 5 to 10 ml, and then we test in the laboratory, and which will tell about the how much is the cell count in the CSF, what is the sugar level in the CSF, what is the protein level in the CSF. So that will also tell about the diagnosis of the brain lesion. Is it infection? Is it inflammation? Which will be cured by only medicines. That differentiation is very important, because all the brain lesions may not need operations. So we have to differentiate between the tumors and such tumor look like lesions, inflammation and infection. So CSF will also give additional guidance to the diagnosis of the patient. So these 2-3 factors are important in the management of brain lesions.
I think so. Initially, you asked what the investigation required. The first and foremost and most important is history. What is
Examination.
history is the most important, and clinical examination. These two will give you 80% what you are going to have, and then rest is all investigations.
Yeah, many patients only come to the doctor's clinic, and the big mistake, they tell what others doctor told them, and they only show the MRI scans and EEG and blood reports. That is zero for us. First, we need a fresh history, and what other doctor said, what other doctor given the medication, that is not important. The most important thing is we should give clear day one history from which the illness started, and then we can clearly diagnose the patient what is the major problem with them. So don't show scans or other doctors' diagnosis to the doctors which you are consulting.
So, when it comes to the brain tumors, there are many prejudices, there are many myths. Which are commonly seen or observed in your day-to-day practice regarding neurosurgery.
Whatever may be number of myths, they are all wrong, and probably we don't believe into it. At least science doesn't believe into it. People do have lots of different assumptions why these things happen or why to that particular person. But probably science has no clue to sort of pinpoint and say these occurrences of tumor is because of this and this and this particular. Except few which was mentioned earlier, like radiation because of some mistake or professional radiation causing problems. Other than that, it's only the genetic. Some genes definitely carry or they get transferred into the descendants cause occurrence of these tumors. Apart from that, there are no myths or any kinds of those assumptions. But of course, what remains important is the perfect perspective given to the patient and the family by the surgeon about the tumor, what it has to be, how do you deal with it? Because dealing with the tumor has so many factors to consider and give a final decision. It depends on the size of the tumor, the location of the tumor, the neurological dysfunction which has come up because of the tumor, possible age which has been there. They ask us, Doc, what do you think, how long this tumor must have been there in the skull for? And then we come to know that some of these benign tumors which grow over a period of many years, some of the tumors grow few millimeters a year. So that's how the growth rate is also. So there are so many different factors and we have to consider those factors, make a diagnosis, and then give that particular decision to the patient whether he needs surgery immediately, later, hold on, because there are so many other factors also in patient's perspective to choose the time of tumor surgery. So they have to be also respected. So basically, we have now known that benign tumors do not cause too much of a deficit. They grow to a bigger size. They grow so slow that they don't sometimes cause any deficit. They are silent over a period of years. Most of the malignant tumors are gruesome. They grow very fast. They cause problems. They cause neurological deficit quite profound. They cause increased intracranial tension quite a bit. And they have to be dealt with very fast. Malignant tumors, you have to make decisions in days and see that surgery is done. Benign tumors, you have a choice of when to do this surgery. Duration, whether 1 week, 2 weeks, 3 weeks, you can wait. Or maybe some of them, there are so many reports to see in the world that certain tumors, without doing anything, are just observed. And every routinely, 3 monthly, 2 monthly, 1 monthly, or 1 yearly MR or imaging is being done, and they are just observed. So I think there are so many perspectives, but according to the surgeon's understanding, experience, consultation with the team, I think very knowledgeable, experienced neurologist also contributes quite a bit to the decision of surgery sometimes, along with surgery. So that also makes a lot of difference.
Regarding the myths regarding whether to operate or not to operate, so initially, we didn't have these equipments to operate on a brain tumor. So initially we used to talk about mortalities in neurosurgery. Whenever I go anywhere, neurosurgery, patients how this is the thing which is there, the tendency neurosurgery means the patient is going to die only. Initially that was the thing. Now with the development of all these equipments, we are talking about morbidity. Morbidity means any deficits are we going to create with the surgery. We are talking no mortality right now. We are talking no. And morbidity also to a very minimum because of this equipment. So you should get it operated. We have better equipments, better results, excellent results I would say, and good outcome. So that thing about a neurosurgery means patient is not going to survive or not going to have, just take it out from you.
Let's think of a past.
Yes.
Dr. Mandar, would you like to add something?
So just don't be afraid to get investigated if any critical symptom is there, and get it investigated as fast as possible. And early the diagnosis, better is the result. I would like to stress on that fact. So early diagnosis needs early consultation, and it leads to better results.
Okay. So now we come to the last part of it, that the patient has been diagnosed with a tumor, he was been operated, and after that, after the recovery, the haunting question for the patient and the family, what if it recurs? So I would like to have some thoughts on that, how it is managed with the team of oncology, that the fear of recurrence, or if there is any recurrence, how do we observe or like evaluate it and how we go about it. So,
I mean, all of us, all three neurosurgeons here will definitely contribute to this particular question because a lot goes along with his or her experiences also. Because more you operate, more the number of years you put in, and more recurrences you see, and you know how to deal with them at the same time. Benign tumors, if they recur, because there is always a chance that a good number of these benign tumors can be completely excised, where they are probably not too avoidable. Most of it, whatever microscope can see as tumor, under microscope a neurosurgeon can make a decision, this is not a tumor, and whatever tumor was there is out. Gives him and a patient complete confidence that yes, most of these tumors are not going to come up again. So this is one category of tumors where we do excise and they do not show up. And for the next 15 to 20 years, now my experience is 25 years in this hospital, where I have exact certain number of patients who have come with recurrences, benign ones I'm talking about. And some of them, they came for first 5 years, we repeatedly monitored them, and there's nothing, so we left there all. So recurrences or in a benign tumor, if well managed, well excised, or almost hardly any chance of recurrence. There are certain tumors where certain amount of tissue has to be left alone because of various different problems. During surgery, prior to surgery or later, and then that particular tumor may come up again. But today, where we may not have to reoperate them again. But in case if surgeon is enthusiastic and patient wants to do it, the best time to reoperate again is within few weeks after the first surgery. That's the best time in case there are some residual tumors. Now this business of residual tumor to get rid of, intraoperative imaging has come into picture. And we don't have, unfortunately, intraoperative MRI in many centers in India. Few centers in India probably have these intraoperative, where total removal of the tumor is guaranteed and known at the time of surgery. Recurrences come up only when tumor remains there or tumor has to be left there. So this is about benign. Small little tumor size where we are deliberately keeping them because they can't be dissected off the brain or eloquent structures of the brain or cranial nerves where the cranial function dysfunction would cause disaster. Then we have to leave that tumor and maybe we could radiate by stereotactic radiation. I mean, stereosurgery, radiosurgery, and ablate those remaining tumor where we remove and rule out the possibility of recurrence. So this is about benign. Regarding malignant tumors, we know that most of them will recur. And then we have already into plan of chemotherapy, radiation surgery, cyberdyne, and so on and so forth. So this is in general how we look at the recurrences. But we are in a perfect position to now come to the patient and tell them that yes, here there is hardly any chance of recurrence. Here there is a possibility because we have to do this. And in malignant, yes, we have to tell them about the recurrences because most of these malignant tumors recur. But of course, now with good removal of the tumor, like for example, I could give you example of medulloblastoma, which happens, which comes up in children, which is supposed to be the malignant tumor, but with smaller tumor, very good clearance, radiation, and if supposed chemotherapy. Some of these children today, in my practice, are living 14 years post-surgery. Absolutely. So there are certain tumors which behave like malignant tumors, but still have very good longevity and very good quality of life. So these are the various variants. Because as far as tumors are concerned, we have about almost 200 types of intracranial tumors.
To add to it, what sir said, that's correct. Then to add to it, basically, radiation initially was very gross. Used to be whole brain radiation, there was a lot of complications related to radiation. Today, let's say for benign lesion, as he said, that if it's very close to a vascular structure or cranial nerve, we prefer to leave it. We don't want to touch it or remove it because it will damage that nerve. And that's why I was telling you, we are talking about morbidity, we're not talking about mortality. We want to preserve the function. So in that case, what we do is basically we radiate them and it is a beautiful result. The patient does not have any recurrence with radiation also. For recurrence, you always have to keep the patient under follow-up regularly. For benign lesions, we do a 6-yearly scan to see whether it's coming up or not. If it comes up and it's in a very initial stage, we can give them radiation. That solves the problem. For malignant, yes, I always say, other than grade 1, grade 2 to grade 4, they are going to recur and it's not cured. Still date, there is no cure to a malignant tumor. But you can improve the lifespan by doing surgeries, giving radiation, chemotherapy, improve the quality of life. But there is no cure till date. So that's what I would say. Anything else more?
So some of the tumors are very sensitive to radiation and few are sensitive to chemo as well. So to take the biopsy, if it is not actionable, and diagnose which type of tumor it is and whether it is radio sensitive like germ cell tumors. So even if surgery is not possible, then these newer modalities can help in a great deal to cure the patient from the tumor. And even if there is recurrence, we can undergo repeat surgery at least once or twice, and depending on the case-to-case basis. And so it gives us a certain increased life to the patient and reduce morbidity.
Thank you. Thank you, Dr. Mandar. So coming to the last question, that how important is the caregiver support while managing a patient, caregiver support while managing a patient with brain tumor? I'd like to have thoughts from Dr. Sandeep Borse, sir. Then we will get the concluding comments from the panelists, and that's how we are going to end this session now. So your comments on that caregiver support.
So post-surgery, so first of all, caregivers or relatives of the patient should understand what is the problem and what is the what effects and how to take care of the patients who have some neurological deficits. In that case, neuro rehabilitation plays a good part, because only doing surgery doesn't finishes the job or doesn't cure the patient. Okay, so whatever the minimum deficit which were there before the surgery, so we have to give them good physiotherapy or cognitive therapy to improve those functions which were initially damaged because of pressure of the tumor or direct effect of the tumors. So with the brain has a neurospasticity, so brain functions, brain's few cells can recover or take over the functions of the damaged tissue. So for that we need a good rehabilitation center and or physiotherapist or speech therapist or rehabilitation therapist can come home and take care of the patients and give good speech therapy or physiotherapy to them to make them mobile, to give them normal life. So this process may last for 2 months to 1 year. So caregivers should give good positive, what you can say, reinforcement to the patient, because patient is depressed after surgery, his mental status may not be positive, so he is always negative. What is going to happen to me now? I have undergone such a big brain surgery, and am I going to recover or not? So yeah, the caregivers should be very positive. Doctors are there to help you, physiotherapists are there to help you. So it is a team process. It is not only doctor and patient. It is between the team of doctors, patient's relative or caregivers, and all the rehabilitation team is involved in the recovery of the patient. So we have everything as a team to manage the patients: a radiologist, neurosurgeon, neurologist, rehabilitation therapist, speech therapist, cognitive assessment. We need frequent cognitive assessment even after the surgery, before the surgery. What part of the brain is going to get indicate or not. And serial assessment of the neurological status of the patient, cognitive status of the patient, to see the recurrence is before the scans, we may assess the new neurological symptom is coming. So serial neurological examination once in 15 days or once in a month is also required apart from the routine CT scans post-operatively. So rehabilitation part is very important to emphasize.
So to add to this, I would just say that Jehangir has all this under one roof: a neurologist, neurosurgeon, neuroradiologist. We have a neuropsychologist. We have a psychologist. What he was trying to tell you basically, before surgery, we evaluate the function of the patient, the deficits, what he has developed because of the tumor, and post surgery again we evaluate that what has happened and how can we help him by simple methods like giving some cognitive exercises to improve those functions. So those things can be done under one roof, and we have those in Jehangir. A speech therapist, why it is important? Because speech therapist does not involve only the patient and the speech therapist, it involves the relatives. The relatives have to understand how to help him to develop that speech therapy. So relatives also are part of the treatment in a speech therapy. Obviously, physiotherapy, everyone knows, physiotherapy is a basic thing. But for this, you have to come to a center rather than doing it at home. If that is the best way to do it, basically.
Yeah, I think maybe concluding kind of a thought, I would say we have seen neurosurgery for brain tumors getting evolved over a period of last almost 33 years, where I am in practice for those particular ailments of the brain. And we have come a long way. We were solely responsible once upon a time as a surgeon to look at treat the tumors. But today, with 25, 30 years later, as he has said, multiple specialties have come together, multiple teams have come together, right from looking at the patient clinically, psychologically, physically, and then getting him in the operation theatre, treat him, pre-surgery, post-surgery, neuro rehab, and then psychological assessment again, and building him up mentally and physically again. It's a long process where multiple teams are involved. And I'm so happy that now today we have all those available with us in this center. And that's why our results, this has now become a tertiary care center where most complicated, difficult ones, which probably cannot manage elsewhere, we probably can manage it here because we have so many different faculties available.
Thank you, sir. Any comment?
Yeah, lastly, I would still say, don't get scared, come, take our help. I'm still telling you, brain tumors can be treated and with very good results. People will have this understanding that no, I will not be treated, I will not. So everything can be treated and with good results. So please come forward and come to do the treatment for brain tumors.
Dr. Mandar. So I thank all the panelists, Dr. Chitre sir, Dr. Khandelwal sir, Dr. Mandar, Dr. Borse sir, for this informative session. Thank you all.
Also, Dr. Manish.
Yeah, I'm Dr. Manish Patil. I'm a consultant neurophysician at Jehangir. Thanks a lot. Thank you.
Thank you.